Hi class. In this lecture, we will discuss drugs used for the treatment of epilepsy. You may have heard the term anticonvulsant in the past. This is an older term that's not used as frequently nowadays to describe these drugs. We usually refer to these drugs as anti-epileptic drugs with the acronym AED. So you'll hear me refer to these as AEDs quite frequently. And the reason why is because the word convulsion and seizure, those terms really aren't synonymous. Seizure is more of a general term, and it applies to all types of epileptic events, whereas the word convulsion is pretty limited. It's really more a description of the abnormal motor phenomena that occur when a seizure occurs, kind of like the jerking movements of a tonic-clonic seizure, which that is what usually comes to people's mind when they think of a patient having a seizure. So like I said, we'll use the term anti-epileptic drugs or AEDs. Your objectives are listed on the slide. They're also listed in Blackboard. And there are some new vocabulary terms. Please be familiar with these. Many of these terms are simply the adverse effects of drug therapy, so you definitely want to know the definitions. So epilepsy is a group of neurologic disorders. It's characterized by excessive excitability of neurons in the central nervous system. Epilepsy can produce a variety of symptoms that range from brief periods of unconsciousness all the way up to violent convulsions. In many cases, these patients will experience problems with learning, memory, and even mood. Prevalence of epilepsy is 2 million persons with a lifetime incidence of 3% in the United States. And the incidence is highest in the very young and the very old. About 60%, maybe up to 70% of patients are rendered seizure-free with treatment, which is great. But if you look at it from the reverse, that means that there's still about 30 to 40% of patients that we can't render seizure-free, which is pretty high. So let's talk about the pathophys of epilepsy. Hopefully you've learned about the pathophysiology of epilepsy in the past, so I'll just do a brief review. But basically, epilepsy is initiated by a synchronous, high-frequency electrical discharge from hyperexcitable neurons, and that's what's called the focus. That hyperexcitability then spreads to other parts of the brain, or what is known as recruitment. So that focus is recruiting other parts of the brain, kind of getting those parts of the brain in on the action, so to speak. And it really depends on location and the neuronal connections to that original focus, how widely disseminated that seizure becomes. So when we start talking about the drugs, you will see glutamate is the major excitatory neurotransmitter, and GABA is the major inhibitory neurotransmitter. So the drugs that we talk about somehow influence the balance of those neurotransmitters in some way, shape, or form. The drugs themselves do not interfere with normal neuronal activity, but rather they prevent rapid and repetitive firing of those neurons, and there are a variety of different mechanisms at the nerve terminal and synapse by which they do this. So causes of seizures, as you can see on the slide, the causes can be quite varied. There could be an underlying metabolic dysfunction that's leading to the seizure. There could be a structural dysfunction, such as a tumor, that's causing that seizure activity. Could be genetic. So in pediatrics, you know, where I practiced for quite some time, we would see newborn babies and very small and very young infants that present with inborn errors of metabolism, which is genetic in nature, and these patients would have would present with seizure disorders. Could be idiopathic, meaning we just don't know what the actual problem is, or it could be drug-induced. And so, for example, beta-lactam antibiotics at high doses, such as penicillins, these can cause seizures. Tricyclic antidepressants, usually when they're at toxic levels, can cause seizures. Even illicit drugs like cocaine, or even alcohol withdrawal in a patient who is addicted to alcohol could present with seizures. So again, you may have some background regarding the types of seizures that are seen. If you do, that's wonderful. If not, not a big deal because you can review this information. There's a nice description in your textbook on page 217. And so take a look at that. A nice description of the different types of seizures because epilepsy is kind of a constellation of different types of seizures. Not all patients have the same extent of disease or the same exact manifestations of disease. So you can take a look at those descriptions. There's also a nice chart on page 217 that outlines the different drugs that we use and which drugs are used for which different seizure types. I do want to mention, in addition to partial and generalized seizures, there is a pretty severe form of epilepsy that develops during the preschool years called Lennox-Gastaut syndrome, and this involves developmental delay for these patients, and it's actually a mixture of the different seizure types. So it could be a mixture of partial seizures as well as generalized seizures. It's a very difficult syndrome to manage. In fact, when I worked at the Johns Hopkins Children's Center, I encountered a patient with this disorder once, and this patient really did have quite a difficult time. Just in terms of management of the disease, it was just quite difficult. So goals of treatment. Obviously, if you can cure the patient, that would be great. Normalize the lifestyle of the patient, prevent physical harm associated with seizures, reduce seizure frequency and severity, and hopefully be able to do all of that by using the least toxic therapy. Problem is, reducing seizures to a level that allows the patient to live as normal a life as possible is the goal. But like I mentioned, it's not always completely possible to completely eliminate seizures. Not all patients, it's not possible for all patients. But basically balancing the desire for complete seizure control with acceptable side effects from drug therapy is what we're trying to do. There are other options besides drugs that can help. So, for patients that aren't able to completely eliminate seizures with drug therapy, some patients will undergo neurosurgery, and this, of all the other options, this usually has the best success rate. Some patients will respond to vagal nerve stimulation. This is pretty widely used nowadays. And some other patients even respond to what's known as the ketogenic diet. The ketogenic diet is a high-fat, low-carb diet. It's been found to be effective in prepubertal children, and it's usually reserved for patients that have very frequent and medically intractable seizures. It is a difficult diet to follow, and it's particularly difficult for these patients because they're also going to be on medications, and in many cases those medications have a high carbohydrate content. So those children who are on the ketogenic diet, or even adults, but it's typically children, in many cases the prescribers work closely with the pharmacy to try to minimize the carb content that's added to their diet from their medications. In many cases, as part of managing treatment, we might be monitoring plasma drug levels. In some cases, these patients are even able to withdraw their therapy if they've been seizure-free for a long enough time frame. The anti-epileptic drugs can be toxic, so promoting patient adherence is important, and also minimizing suicide risk because these drugs can actually cause death if your whole prescription is taken at once. So kind of managing and balancing all of these different goals is important. All right, so let's move on to the pharmacology of these drugs. So not all seizures respond to all of the AEDs the same. I already mentioned that. Some have effect in certain seizure types and some have no effect in those seizure types. Only one drug treats virtually all seizure types, and that's valproic acid. Again, you can take a look at that chart on page 217. As I said, it outlines nicely which drugs are effective for which seizure types. So let's actually look at the individual drugs, and we'll go through the pharmacology of each. So how these drugs work, a lot of these drugs will work on a single receptor, or some work on multiple receptors to decrease seizures. The information on this slide here, I'm going to tell you this is informational in my opinion. You do not need to memorize this information from my perspective. I would not test you on this. I don't think that knowing the mechanism of action for the different anti-epileptic drugs helps you clinically in any way, shape, or form. I do, however, think it gives you a kind of broad-based understanding of the drugs. So that's why I'm including it in our lecture. So for some drugs, I am going to say you have to know the mechanism of action. For these drugs, while we do present it, I don't think you need to memorize it. But just so you know, these are the common mechanism of actions that the various drugs work through. So suppression of sodium influx or suppression of calcium influx, promotion of potassium efflux, blockade of receptors for glutamate, potentiation of GABA. Remember, I said those are the two neurotransmitters that kind of balance each other out in terms of excitation in the CNS. Again, just kind of understanding that these are some of the mechanism of action, but not necessarily memorizing these for each drug, I think is what makes sense. So there are two major categories for drugs that treat epilepsy. The traditional anti-epileptic agents. There are 7 of those total. We are going to review 6, actually we'll review, I guess, 7, all 7 of those. And then there are the newer agents. We're only going to talk about 2 of those, but there are actually 13 or even more that are on the market. Just so you know, both the traditional and the newer agents have their advantages and disadvantages. There really are only a few direct evidence-based comparisons. You can check out table 24.3 on page 221 of your book. It is a nice comparison. But just kind of in general, the traditional agents, they have extensive drug-drug interactions. I think that's the main thing to know. So I'm not going to require that you guys know every single drug-drug interaction, but I think as a group, knowing that these drugs have a lot of drug-drug interactions is going to serve you well. Because when you're about to administer phenytoin to one of your patients, I want you to stop and think, wait, this drug has a lot of drug interactions. I got to make sure that this drug's okay to administer with all the other medications my patient's taking. Complex pharmacokinetic parameters, especially phenytoin, the first one listed here. So that's kind of a drawback for these drugs, the fact that the pharmacokinetics can be complex. They're less well tolerated, so they do have a lot of adverse effects, a lot of weird adverse effects, a lot of serious adverse effects. Now the upside is they're prescribed more widely. They've been in clinical use for, in some cases, more than 50 or 60 years. So because of that, we have a lot of data and we have a lot of good info on how to use these medications in this population. One other big issue for the traditional agents is that almost all of them cause some form of teratogenesis. So these are of concern in pregnant patients with epilepsy. And so that's an important factor. The newer drugs, less clinical experience, so that certainly is a downside. But there are evolving therapeutic uses, I would say, or maybe kind of a therapeutic niche for some of these drugs. But they're newer, so they're more expensive. In many cases, there's not a generic form available. Some of these do have some concerning drug interactions. Some of them do have concerning adverse effects. I think it's important to think about the fact that neither the traditional drugs or the newer agents are considered superior. I think the decision to use one or the other is based on the seizure type, and it's based on the patient's underlying variables. And so there's really, kind of a consideration of all these factors and then a decision as to which agent would be the best. So let's start with the traditional agents. I'm going to start with phenytoin. I have to tell you, I think you're going to recognize this when you start to look through these slides. I've got more slides on phenytoin than any other drug that I'm going to present today. And that's because this drug is definitely one of the most commonly used anti-epileptics, but it's also very complex. So there's a lot of information to know about phenytoin. So it is one of the most widely used anti-epileptic drugs, despite the fact that it has tricky pharmacokinetics, and it does have some pretty bad adverse effects associated with it. The drug is used for epilepsy all types, almost all types of seizures, except for absence seizures. It's also used for some types of dysrhythmias. We're not going to talk about that today, but when we talk about the antidysrhythmic drugs in a few weeks, we will talk about phenytoin again. So the thing about phenytoin is that its pharmacokinetics are pretty complex. First of all, it is extensively protein bound, normally more than 90% protein bound to albumin in the plasma. And this can be decreased in the setting of patients with hypoalbuminemia or patients with renal dysfunction or even patients with drug-drug interactions. So for example, valproic acid actually bumps phenytoin off of its protein binding site, which can temporarily increase your levels of phenytoin, which can lead to toxicity. So that's, that can be a consideration when using phenytoin. It has a narrow therapeutic index. You have to know this. It's a very narrow therapeutic index drug. And this is secondary to the kinetics of this drug. This drug has what's known as saturable kinetics. And so what that kind of comes down to is that the doses needed to produce a therapeutic effect are only slightly higher than the doses needed to overwhelm the enzymes responsible for metabolizing this drug. And why that is because those enzymes are saturable. I'm not going to get into more detail than that. I think that's about what you need to know. But the fact that the enzymes can get saturated, so they are overcome very quickly. So the difference between the dose that's working very well for the patient and then, if the dose continues to be pushed to the point where the kinetics are saturated, then the patient starts to exhibit signs of toxicity. You may remember this chart. So I showed you this chart when we were talking about drug response and kind of the dose versus the drug level response when we were talking about general principles of pharmacology. But look at the screen. You see your minimum effective dose and then your toxic dose, and you can see that window between those two is pretty small. Whereas for a typical drug, you can see that minimum effective dose and then your dose needed to produce a toxic dose is quite wide. And so that's why phenytoin is considered a narrow therapeutic index drug. So in terms of the adverse effects, your sedation and other CNS effects can be pretty profound. And you can see kind of what this looks like in terms of drug levels. So sedation or nystagmus. Nystagmus is just continuous back and forth motion of the eyes at levels that are above 20 mics per mil. And by the way, the typical therapeutic range, blood level range for phenytoin is anywhere from 10 to 20 micrograms per mil. So when you start to exceed that, just slightly, you see sedation and nystagmus. But you can see sedation at lower levels. So some patients, even in the therapeutic range, will experience sedation. And then as those levels continue to climb, you may see ataxia, which is just staggering gait, mental changes like delirium or psychosis or depression. And then when you get as high as 50 mg per mil, coma, and then even above 100 mg per mil, that's considered lethal. So for this drug, this is a drug that's conducive to monitoring drug levels and something that for some patients we will look at, especially if you see patients that seem to be exhibiting signs of toxicity. There are also non-CNS associated adverse effects. I have a couple highlighted on this screen. Gingival hypertrophy. This is a really important one. This is overgrowth of gums, of gum tissue, and can be very severe for patients, but can be minimized by good oral hygiene, can be minimized by taking folic acid supplementation each day, can be minimized if you teach your patients to floss, do gum massage, and just all around have good oral hygiene. Skin rashes are a serious side effect of phenytoin. Anywhere from 2 to 5% of patients on phenytoin will exhibit a morbilliform type rash, which is a measles-like type rash. This can progress to Stevens-Johnson syndrome or toxic epidermal necrosis. These are very serious and can cause serious morbidity and even mortality for patients that experience those serious syndromes. It is believed that there's a genetic predisposition to developing either Stevens-Johnson syndrome or toxic epidermal necrosis. That's important to know. Some patients even experience hirsutism, which is overgrowth of hair. Some patients experience sexual dysfunction or even cardiovascular effects, such as hypotension or dysrhythmia. Those cardiovascular effects are related to the IV form and how the medication is administered. It has to be administered slowly and can't exceed more than 50 milligrams per minute. Normal saline has to be used as the carrier or the flush. You can't mix this drug with anything else. And if the drug infiltrates, which means that the needle leaves the vascular space and the medication spills into the surrounding tissue, that can lead to severe extravasation and tissue necrosis. So we generally only give phenytoin into large veins, and it's always flushed well with normal saline. I'll talk a little more about this when I talk about nursing implications. Individual variation, so patients with renal or hepatic dysfunction, there can be issues administering this drug to those patients. Drug-drug interactions. You need to know that this drug is a potent CYP450 inducer. You should already know that because I asked you to memorize that as part of the drug-drug interactions lecture. You have to know that because if you're getting ready to give phenytoin to a patient who is on a drug that's metabolized by the specific CYP450 enzymes, then most likely that patient's dose of that other drug needs to be increased. So this is something that's important to know. Phenytoin is also, the levels of phenytoin can be either increased or decreased by other CYP450 inducers or inhibitors. And then I do think it's important to mention that CNS depressants can cause additive CNS effects with phenytoin. But bottom line, definitely know that phenytoin is an inducer. Nursing implications, it's not given IM. In terms of IV administration, I already mentioned not to exceed, especially not to exceed more than 50 milligrams per minute. Rapid injection can precipitate cardiac arrhythmias, and blood pressure and EKG need to be monitored if this medication is given intravenously. The solutions are highly alkaline, may be irritating to the veins, so only should be administered into large veins. Must monitor for extravasation. Normally, you don't leave the patient's bedside when you're administering phenytoin. And then only mixed or flushed with normal saline. Okay, so some additional nursing implications. Phenytoin can be taken with meals to reduce GI upset. Phenytoin, when given with tube feedings, can result in reduced bioavailability. So the recommendation for giving phenytoin together or for a patient who's on tube feedings is to separate them by at least 2 hours. So that means turning the tube feedings off 2 hours before you're going to give phenytoin, and then administering the drug, and then turning the tube feeds on back 2 hours later. And so this might seem counterintuitive to you guys. You might think, well, wait a minute, you just told us to give it with meals to decrease GI discomfort, but now you're telling me that we can't give it with tube feeds, and that seems a little unusual. Well, possible reasons for the decreased bioavailability when the med's given with tube feedings as opposed to reduced bioavailability when it's given with just meals. The tube feedings themselves, there's a couple things that could be going on. First of all, the drug could be adhering to the tubing, so that's one possibility of why bioavailability is decreased when it's given with tube feedings, but it's not decreased when the medication is given with meals. Another reason is the formulations that are used for enteral feeds are very concentrated. They tend to have high amounts of proteins as well as divalent cations like calcium the concentrations are much higher than what you might see just in regular food. So that's another possible reason why when phenytoin is given with tube feeds, we do see bioavailability issues that can lead to therapeutic failure. So just understand that you can give it with food to reduce GI upset. However, it's not recommended that we give phenytoin along with tube feeds, and that we actually do take measures to separate those from each other so that the bioavailability of phenytoin is not affected when the patient's also getting tube feeds. Additionally, we don't discontinue this drug abruptly, just like any antiepileptic. We don't discontinue the drug abruptly. And it's really important to provide patients with adequate education about how to avoid those adverse effects. I mentioned gingival hyperplasia, for example. So, what things could you recommend to your patients to prevent that effect? And then lots of other effects. So, definitely take a look at the nursing implications section of the chapter and be familiar with that education. So, moving on to fosphenytoin or Cerebix. I hope wherever you work that you guys will use this drug instead of intravenous phenytoin. Fosphenytoin is a prodrug. It's recommended for use when oral phenytoin can't be given, rather than using IV fosphenytoin because of all the difficulties with IV administration of that medication. The good thing about fosphenytoin is that everything about it is the same as phenytoin. So it's the same mechanism of action, same adverse effects, the same therapeutic use, same drug-drug interactions. But the only difference is that the IV administration issues are less severe with fosphenytoin than they are with phenytoin. There is one other major difference. It's administered in phenytoin equivalents. So, your loading dose is the same as for phenytoin. It's 1 milligram of phenytoin equals 1 milligram of phenytoin equivalents. It's just, it's just a weird way of expressing the dose. But the good news is it's 1-to-1. So, when you're whatever milligram dose you would have given of phenytoin, it's the same milligram dose that you would have given for fosphenytoin, except the label is going to say milligrams PE, which is phenytoin equivalents. It can be given IM, unlike phenytoin, which should not be given IM. And there are no oral dosage forms. So if you're going to give an oral form, it would be oral phenytoin. It's safer than phenytoin via the IV route, as I already mentioned. You can administer it faster, 100 to 150 milligrams of phenytoin equivalent per minute, causes less phlebitis, less tissue damage at injection site. So it's clearly a preferred agent over phenytoin IV. Some medication safety concerns with phenytoin and fosphenytoin. First of all, phenytoin is considered a high alert drug. And that's because of the fact that it has a narrow therapeutic index. And if toxicity does occur, it can be life-threatening. Additionally, phenytoin, when given via the IV route, has quite a few administration issues, as I've already mentioned. Sometimes there's confusion with fosphenytoin in terms of the dosing. So just those weird units. But as I mentioned, it's just 1-to-1 dosing, so I wouldn't let that get you too tripped up. Finally, failure to shake the oral suspension. This can be deadly, actually. So if your oral suspension, and this is typically an issue for patients and parents at home. So if you've got a bottle of fosphenytoin, it has to be shaken well because it's a suspension. And suspensions settle when they're just sitting on the shelf. And so before you drop the dose, you have to shake it well. There have been cases where patients don't shake the bottle, they draw the dose off until they get down to the bottom of the bottle, and then when they get to the very bottom, it's all drug kind of settling at the bottom of the bottle. They give their child a dose, and it causes death for that patient because they receive a massive overdose in that one single dose. All right, so let's move on to carbamazepine. Its mechanism of action is similar to phenytoin. It's used in several types of seizure disorders. It does have fewer adverse effects than phenytoin and also phenobarb, which is another drug we'll talk about in a few moments. So it's generally preferred to these agents. In terms of therapeutic use, its main use is for epilepsy, but it's also used for bipolar disorder. We're going to talk about that in a few weeks. And it can also be used for trigeminal and glossopharyngeal neuralgias. We're not going to talk about those in our course, but that is potentially another therapeutic use. In terms of drug-drug interactions, this drug is a potent inducer. You should already know that. We talked about that in our drug-drug interaction introductory lecture. Phenytoin and phenobarbital specifically can induce carbamazepine. So I don't have that bolded on the slide, but that is a concern. And I did bold grapefruit juice. Grapefruit juice can inhibit the metabolism of carbamazepine, and so patients should not drink grapefruit juice when they're on carbamazepine. Interestingly, because carbamazepine is a potent inducer, it in fact induces its own metabolism. So when the drug is first administered to patients, the half-life of the drug is pretty long, up to 40 hours. But as the patient takes the drug over a period of days to weeks, it actually begins to induce its own metabolism. It takes I'd say about 2 to 3 weeks, maybe even up to a month, to kind of fully generate that induction. But this is really more of kind of a theoretical or interesting fact about this drug, because the way it's dosed, usually over that first month, the dose is slowly increased. So neurologists that are prescribing this medication will slowly increase that dose over the course of several weeks to account for this this interesting fact of the fact that it induces its own metabolism. So adverse effects, and you can see there are quite a few. So luckily this drug has minimal effect on cognitive function, unlike some of the other antiepileptics, and that's the primary reason for selecting this over other drugs like phenobarbital or phenytoin. But it does cause some neurologic issues. But luckily, tolerance will develop to some of these neurological problems like diplopia, headache, ataxia, and so over the course of a couple weeks, again, this is why the drug is kind of one of the reasons why the drug is slowly titrated to a higher dose, is because that tolerance can develop and those neurologic symptoms will subside. And it can also be minimized by using the lowest effective dose, and also giving the largest portion of the medication dose at bedtime. Some other serious adverse effects, though. So some GI problems. These aren't necessarily serious, but these are problems that patients may encounter. Hyponatremia secondary to SIADH, which is syndrome of inappropriate antidiuretic hormone release. This can be a problem for patients on carbamazepine. And when Dr. Velez goes over her case, I think this is one of the problems that her patient was experiencing when on carbamazepine. It can also cause serious bone marrow suppression. Leukopenia in about 10% of patients. The good thing about leukopenia, is that in many cases it subsides. However, in some patients it does not. So if white blood cells drop below 2,500, then generally the medication needs to be discontinued. Thrombocytopenia and anemia occurs in about 5% of patients and requires that the medication be discontinued. And then also some patients do experience aplastic anemia. As many as one in upwards of 200,000 patients will experience this, and it can be deadly. Luckily, it is relatively rare. Rash, you need to know this. I wish I had bolded this on your slide. Rash is a very important side effect of carbamazepine. It occurs most frequently in patients with a specific genetic disposition for it. So they have the HLA-B 1502 allele, and so it's recommended that for patients who are starting carbamazepine that they're screened for this, because if they do have this allele, the rash can be serious. Finally, carbamazepine can be teratogenic. Like phenytoin, carbamazepine can cause serious teratogenicity, and so for patients who are pregnant, or may become pregnant, this is a very serious adverse effect to be monitoring for. And so birth defects such as spinal bifida can occur. So if the patient's pregnant, there is a serious risk-benefit discussion that needs to happen. And usually the drug will be eliminated, and some other antiepileptic that does not cause seizures would be used. However, it really will depend on the patient. If the patient has a very serious epileptic disorder that has not been conducive to use of other medications, then there's that risk-benefit ratio to consider. Nursing implications: the medication should be given with meals, and there should always be education regarding avoidance of those adverse effects, ways to monitor to minimize the problems associated with those adverse effects. There are multiple different dosage forms that are available for carbamazepine with a variety of dosage schemes, so given once a day, twice a day, 3 times a day. So those can be a source of safety issues with this medication. Let's move on to valproic acid, another well-known traditional agent that's been around for quite some time. I guess up front, the issue with valproic acid is that there are 3 different chemical forms of this drug. Just straight up valproic acid, valproate, which is the IV form, and divalproic sodium, which is a complex of 2 valproic acid molecules that's converted to a single valproic acid molecule after absorption. So there can be some confusion around these different forms. The good thing to know is that they're all equally effective. It's just these different forms that are available. And so this drug is widely used to treat all kinds of seizures. It's actually the only drug that's used to treat every single type of seizure disorder. It's generally pretty safe, except there are pretty rare cases of hepatotoxicity with liver failure, and the drug can also cause pancreatitis. Otherwise, it's pretty safe, but we'll talk about some of the adverse effects that you may see with this drug. Therapeutic use, the majority of people who use this drug it's for epilepsy. We do see some use nowadays for bipolar disorder, which we'll talk about in a few weeks. It could also be used to treat migraine. Adverse effects, I already mentioned the 2 that I have highlighted on this slide. Hepatotoxicity, very serious liver damage can occur. It is pretty rare, approximately 1 in 49,000 adults. However, it's more common in children, 1 in 500 children. Most cases that are seen are in children less than 2. Just in general, patients can see a mild elevation of liver enzymes, but some patients will have, this will progress to very serious liver damage. If it does occur, it usually occurs in the first few months of therapy. Pancreatitis, you can see the numbers of kind of what you might see, how frequently this might occur. But you should educate your patients. Watch for abdominal pain, nausea, vomiting, anorexia. It could be seen in both children and adults. And it can be seen anywhere in therapy, in the beginning all the way up to years later. So patients definitely need to be educated on the signs and symptoms of pancreatitis so they can seek prompt treatment. Could also cause just kind of some of your run-of-the-mill side effects like nausea, vomiting, diarrhea, hair loss, bruising. The good thing about this drug, it causes very little sedation, does not affect cognitive skills. Therefore, it's good for kids in particular, except you have to kind of balance that risk of hepatotoxicity. Could cause weight gain. It's highly teratogenic, especially in the first trimester. So women who are thinking of becoming pregnant should not be using this drug. Women who do become pregnant, there needs to be a discussion around whether this drug should be continued or not. Drug-drug interactions. Remember, the traditional anti-epileptics have a lot of drug interactions, and so this drug increases the levels of phenobarbital, phenytoin, and it also, the levels of valproic acid can be decreased by carbapenem antibiotics like meropenem or imipenem. When we talk about those antibiotics, I'm going to tell you that you have to know that. Because if one of those drugs is started for a patient on valproic acid, most likely that patient's plasma levels of valproic acid are going to drop. They're going to experience breakthrough seizures. I saw this time and time again at Johns Hopkins in the various ICUs when patients would have a serious infection requiring a carbapenem antibiotic, and they also had an underlying seizure disorder, and they were on valproic acid. It caused a problem. Some nursing implications: give with food to decrease the GI effects. Sprinkle caps can't be opened. They can be opened and put on food, but you can't chew or crush those. Some safety concerns: all those different dosage forms can cause problems. Suspensions need to be shaken well. And I would say that this drug is generally avoided in patients less than 2, because remember, those patients are at the highest risk for liver failure from this medication. Ethosuximide, this is going to be a brief discussion. This drug, really all I want you to know is that it's the drug of choice for Absence seizures. I think that this is something you might be asked on your NCLEX exam. Generally, the good thing about this drug is it's very well tolerated. It's extremely effective. For those patients who have absence seizures, it works more than 90% of the time. For the most part, it's well tolerated, but there are some rare adverse effects, and you can see some of those that I have listed on the screen. Let's move on to phenobarbital. This is, again, one of your traditional agents. It is one of the oldest anti-epileptic drugs. It's very cheap, but it has a lot of adverse effects. It's not used all that frequently to treat patients with seizure disorders. It's been replaced by a lot of the newer agents and even some of the traditional agents that are a little bit better tolerated. It's used in epilepsy. It's also used as a sedative agent. And we'll talk about sedatives in a couple weeks, and I will talk about this drug again. Phenobarbital is in the barbiturate family. Most barbiturates produce generalized depression of the CNS. This drug produces anti-seizure activity and only mild CNS depression, relatively speaking. So compared to some of the other barbiturates, phenobarbital is really just a mild CNS depressant, but we'll talk about some others that cause significant CNS depression. In terms of pharmacokinetics, there does need to be a loading dose, which means you have to give a lot of it up front and then a maintenance dose thereafter. It does have a very long half-life, up to 96 hours. Remember I said most half-lives, it's anywhere from hours to maybe up to a day. But this drug has a very long half-life. So when the drug's discontinued, the drug's going to remain in the body for 4 to 5 half-lives. You do the math. Remember, 4 to 5 half-lives for this drug's going to be several weeks. The dose should be tapered slowly to prevent an exacerbation of seizures. We never, with any anti-epileptic, we never abruptly discontinue the anti-epileptic. And I'll talk about that at the end of this presentation. Adverse effects, dependence is one of the big ones. I have that highlighted on the slide, but I did mention CNS, drowsiness. In kids, it's actually can cause kind of a paradoxical effect, actually causes ADHD or hyperactivity. The drug can also interfere with vitamin D absorption, so if patients who are on this for a long time can present with rickets or osteomalacia. And also I have in italics, teratogenic. This drug is teratogenic, so it needs to be used cautiously in patients who are of childbearing age. Also, overdose is a significant concern for this drug. It can cause CNS depression. In high doses, it can lead to lethal CNS depression and death. It's contraindicated in patients with intermittent porphyria, and the dose does need to be adjusted in patients with severe liver disease. A potent inducer, you have to know that. You should already know it. That was something I asked you to memorize for your drug-drug interactions. It should be given over, IV administration should be slow. This drug can cause extravasation, so the IV site needs to be monitored. And again, safety concerns, excessive doses of phenobarbital can lead to toxicity, moderate symptoms, nystagmus, ataxia, severe overdose can lead to CNS depression and death. Let's move on to the newer agents. Remember, I said there were 13 of those altogether. We're going to talk about 2 of those. Generally, they're considered equally effective in relation to the traditional agents. They are prescribed less, I would say, just because clinical experience is still somewhat limited. Some of the advantages, some of these drugs have fewer side effects and less complex pharmacokinetics, but they are pretty expensive. Some of them do still cause teratogenesis, like oxcarbazepine, which is what you see on the screen here. But kind of all in all, they do tend to cause less adverse effects. Carbamazepine itself is a derivative of, oxcarbazepine is a derivative of carbamazepine, which we already talked about. It is less likely to be teratogenic, but it still can cause teratogenesis. It is less likely to cause serious drug-drug interactions. The newer agents are less likely to cause serious drug-drug interactions. However, oxcarbazepine is implicated in some serious drug-drug interactions, and that's because it's structurally similar to carbamazepine. It is used for the same indications as carbamazepine. It's got the same efficacy as carbamazepine. Overall, I would say it's better tolerated. it does have a higher incidence of hyponatremia compared to carbamazepine. So, I mentioned that hyponatremia secondary to SIADH is something that's seen with carbamazepine, and actually oxcarbazepine actually causes more hyponatremia. Um, like carbamazepine, oxcarbazepine can cause serious skin reactions, and there is about a 30% cross reactivity. What that means is, if you have a patient who has experienced a serious skin reaction with carbamazepine, they probably should not get oxcarbazepine, and vice versa. Drug-drug interactions, there are a couple I think are important that bear mentioning. Number one, oral contraceptive levels can be decreased by oxcarbazepine. Phenytoin levels can be increased by oxcarbazepine, and alcohol does cause additive CNS effects, very similar to carbamazepine. Lamotrigine, the other new drug that I want to mention, the other newer agent I want to mention, brand name Lamictal. This drug is an important drug. It's very commonly used. It's used quite frequently for epilepsy, but it's also used quite frequently for bipolar disorder. So I will talk about this drug again. Drug-drug interactions. What I want you to know here is that lamotrigine is impacted by those potent inducers and inhibitors. So because of the way lamotrigine is metabolized, if it's used with a potent inducer inhibitor, the levels of lamotrigine can be impacted significantly, such that the patient could experience either therapeutic failure in the case of concomitant use with an inducer, or toxicity in the case of concomitant use with a potent inhibitor. Some adverse effects that are important to mention. Generally, this drug's well tolerated. However, CNS effects are seen. And then I would be remiss if I didn't mention the black box warning. A black box warning is something that the FDA requires when a very serious life-threatening adverse effect is associated with a drug. So rash, you absolutely have to know that Lamictal is associated with life-threatening rash. You can see the numbers on the slide. It's more common for this rash to be seen in children than adults, but it's relatively common in both groups. Most reported cases have been reported within 2 to 8 weeks of starting therapy, and generally not seen after 6 months of therapy. First sign of rash in these patients, the drug needs to be stopped. And I mentioned previously that sometimes you will titrate your dose up for to prevent other adverse effects. Same thing with lamotrigine. We generally slowly titrate the dose up because we want to look for that rash kind of in the early stages. And if you slowly titrate the dose, you might see that side effect before you're kind of at your full therapeutic dose, and in which case you could see a more severe rash. Aseptic meningitis is rare, but is another serious side effect that has been seen with lamotrigine therapy. Finally, this drug can be teratogenic. There is a small risk for cleft palate. So I'd say of all the drugs I talked about today, the lowest risk is with lamotrigine, but the risk is there. Finally, before I conclude my discussion of antiepileptics, I want to talk about status epilepticus. This is a medical emergency. So 125,000 Americans each year experience status epilepticus or SE. 20% of those die. So this is a pretty serious medical emergency. Needs to be quickly recognized and quickly treated. I'll tell you, a friend of mine who had epilepsy as a child, who was off anti-epileptic drugs as an adult, had been off of them for many years. She started feeling weird for a few days, made a doctor's appointment. Unfortunately, before she was able to be seen by her physician, she experienced status epilepticus, and she actually died as a result. Very, very, very sad situation when that happens. So it's a medical emergency. It's categorized by a continuous series of tonic-clonic seizures, lasts for at least 20 to 30 minutes. The patient loses consciousness during the entire attack. The patients may experience tachycardia, elevated blood pressure, hyperthermia, hypoglycemia, acidosis. These are some of the other conditions that these patients begin to experience. Can cause permanent neurologic injury or even death, as I've already mentioned. Treatment really needs to commence within 5 minutes. And basically what you're trying to do here is maintain ventilation, correct underlying hypoglycemia, and really you want to terminate the seizure as soon as possible. In many cases, you're trying to get an IV line in so that you can draw blood glucoses, electrolytes, drug levels, things of that nature. In terms of how it's treated, drug of choice generally are benzodiazepines. You could either use lorazepam, which brand name is Ativan, intravenously, or diazepam, brand name is Valium. That can be either used intravenously or rectally. These drugs work, benzodiazepines work basically by increasing GABA activity, and so that influences the termination of seizures. So benzos themselves are anticonvulsants. They also relax muscles. They're sedatives and they're anxiolytics. So we're going to talk about them again a few more times, but they are anticonvulsants, and that's why they're useful for status epilepticus. In terms of administration, I got this out of your book. I don't normally require you to memorize dosing, but I do think because this is such an acute thing that's being treated, I think it's wise for you guys to be familiar with the dosing. And you could see these patients anywhere. You could see them on a general unit. You could see them in the ICU. So there's no guarantee that you guys won't see these patients when you're practicing. So this is the adult dosing. Clearly the peds dosing would be different. Lorazepam, 4 milligrams, no faster than 2 milligrams per minute. So you draw that up and give it over 2 minutes. And the effect of lorazepam, because it has a long half-life, it lasts up to 72 hours. Diazepam, on the other hand, has a pretty short half-life, and so follow-up therapy will be needed. You might even give more than one dose of diazepam to abort the status epilepticus. So 5 to 10 milligrams IV every 5 minutes. It could be given every 5 to 10 minutes. No faster than 5 milligrams per minute. Max dose that you would give in a single session would be 30 milligrams. This is available as a rectal gel. The adult dose is 10 milligrams. The rectal gel is actually very useful because in the outpatient setting, patients who are prone to status epilepticus, this dosage form can be dispensed to them, and somebody, a family member could give this to them rectally if they're experiencing a status epilepticus episode. It also can be used in the hospital. So, if you can't give the patient IV therapy, you could give them rectal therapy. You could repeat that dose once. All right, so let's wrap this all up. I don't normally do this, but for the AEDs, nursing implications are absolutely vital. These drugs, like I mentioned, they cause toxicity. Some of them have a narrow therapeutic index. They have a lot of adverse effects associated with them. They're just all around issues associated with these medications, even administration issues. So I'm going to kind of summarize some nursing implications that really span across all of the different anti-epileptic drugs. General ideas. First of all, the dosing for these. Now, we don't ask you guys to memorize dosing, but just so you know, when you're out there in clinical practice, the dosing is highly individualized. So the dose you might see, if I were your patient, versus if Dr. Velez were your patient, if the two of us had seizure disorders, could be quite different, even if we were on the same drug. Minimizing danger from uncontrolled seizures is very important. So making sure patients don't abruptly discontinue their medications because that can lead to status epilepticus. Addressing suicidal thoughts and behaviors associated with these medications. These medications have CNS effects. And because of that, they can lead to some of these suicidal thoughts or behaviors. And then in addition to that, these drugs are toxic. So if the patient understands that if they drink the whole bottle of phenytoin, that can lead to suicide or that can lead to their death, kind of addressing that up front, it would be very important. And usually this is on the part of the medical team. And then use in pregnancy. So making sure patients know that these drugs can be teratogenic. They have to use effective forms of birth control. If they're planning to become pregnant, or even if they're not planning to become pregnant, these drugs it's really important for patients of childbearing age that they're using effective birth control. I already mentioned the pregnancy categories, right? So with all of these drugs, I mentioned that they're teratogenic, some more so than others. Those category D drugs like phenytoin, phenobarbital, valproic acid, these are highly teratogenic, and you should definitely know that. Patient education is of the utmost importance for patients with a seizure disorder. So everybody's got to be a part of this. maybe suggesting things like keeping a log of your seizure activity, wearing a medical alert bracelet, understanding the chronic nature of your disease and how important it is to be adherent to therapy, discussing those adverse effects with patients, explaining to them what to look for. For example, I talked about, certain drugs causing pancreatitis, making sure they know what to look for pancreatitis, because if a patient's developing pancreatitis, it's important to get prompt treatment. That's just one example. Discussing the need for dose or drug changes that might, along the course of therapy, be needed, and even that some drugs do require monitoring via blood levels. And so, for patients and for you guys as nurses, noting when your level was drawn in relation to the dose administration. Remember, I said therapeutic drug monitoring, everybody's a very important part of that. The recognizing the need for therapeutic drug monitoring, maybe the prescriber might do that, maybe the pharmacist or the nurse may do that. Um, Accurately drawing those blood levels and noting when they were drawn and noting when drugs were administered in relation to those blood levels. That's really important, and that's especially important responsibility for nurses. And then just the goal of drug therapy. So for these drugs, having a trough, that's the lowest level prior to the next dose. So a trough that's high enough for the drug to work, but peaks, and peak is, once the drug is administered, the highest concentration you would see after that dose is administered. So peaks that are low enough to avoid dose-related toxicities. So when healthcare professionals are looking at these levels, that's generally what they're looking for. But it's not just a numbers game. We're also looking at symptoms. So correlating the patient's symptoms in conjunction with those numbers. Finally, I would be remiss if I didn't mention withdrawing AED therapy. Not all patients are candidates to have their anti-epileptic drugs withdrawn. Some are. If that's the case, the drug will be discontinued very slowly over the course of several months, generally over the course of 3 to 6 months. These patients need to be monitored very closely for that 1 year after their drug has been withdrawn for the reappearance of seizure disorders. And generally, they're educated that your seizure disorder could come back at any time. And so they're usually educated around symptoms they might start to look for. For example, I told you that a good friend of mine had a seizure disorder as a child, and she was told that her disease could come back, and what to look for. And she started to recognize those symptoms and made an appointment to see her physician, but unfortunately she didn't get there quick enough. So that's kind of the picture for withdrawing AED therapy. So just know that it is done sometimes, and that it's done with caution. And then when it is done, there's a lot of caution around how it's done. All right, guys, that's it. Any questions, please post them on the discussion board. I'd be happy to answer those. I think this is a really important lecture. I personally, because I've had friends with this disease, I've had patients with this disease. I've seen, as a pharmacist, I've seen all the different manifestations of adverse effects from these medications. But there are ways to minimize those adverse effects while maximizing the therapeutic effectiveness. And I think you guys as nurses play a vital role in that. So if you have questions, please post them. I'd be happy to answer them.